Okay, how's it everyone? Thanks for coming. It's nice to be able to talk at these things and just chat about these topics. I mean, I'm definitely really stressed out, so I know our patients are very stressed out as well. So just a quick summary on what we're going to do today, if that works. I'm just going to stick there. So just going to quickly cover some physiology and then go over the topic of adrenal insufficiency, and then basically these concepts that will more affect patients in the ICU setting, and then assessment and management of those patients. It's quite a quick flow through, so hopefully shouldn't take too long. Just a quick coverage again of the adrenal glands. The adrenal has 3 layers, conveniently labeled GFR, glomerulosurfaciculata, and reticularis. And each of these layers produces a different major hormone. Important thing is that all 3 layers of the cortex actually secrete corticosteroid, so the precursor to cortisol, but only the glomerulosa secretes aldosterone, and then the medulla is responsible for secreting catecholamines. And this little structure can cause a few big issues. So we talk about the hypothalamic pituitary adrenal axis, the HPA axis, and kind of endocrinology is based on negative feedback loops, and this is one of the best examples of that the hypothalamus regulates the pituitary gland, the anterior pituitary specifically, which regulates the adrenals through negative feedback. And the hypothalamus stimulates the anterior pituitary gland by releasing corticotropin releasing hormone, and it travels through to the anterior pituitary through blood vessels. And then the anterior pituitary secretes ACTH, adrenocorticotropic hormone, into the bloodstream, which then travels to the adrenals and stimulates the production of, among other things, cortisol, which then negatively feeds back on those 2 precursors. And that's how this whole system is controlled. Just to go through some physiology, that's important to understand the effects of this. The renin-angiotensin-aldosterone system, aldosterone being the end organ or the end hormone that's important in understanding this. But effectively, you've got stimulation of the system through low blood pressure or low sodium, which causes an increase in renin, which then takes angiotensinogen and converts it to angiotensin 1 in the liver. Angiotensin 1 is converted to angiotensin 2 by the angiotensin converting enzyme, which primarily takes place on the pulmonary endothelium. And then angiotensin 2 has 4 major functions, one of which is increasing the production of aldosterone. And aldosterone itself has 4 major functions. So you can see that it increases the number of the ENaC channels in the principal cells in the luminal membrane, in the proximal collecting tubule. And this causes increase in sodium resorption from the urinary filtrate. It also causes an upregulation of the sodium-potassium pumps, thereby increasing sodium resorption and effectively facilitating potassium secretion, because that's on the basolateral membrane, and on the luminal membrane there's the ROMK, which causes excretion of those potassium ions into the filtrate. And then the last thing it does is upregulate the sodium-potassium pump, which causes NH4 plus ammonium secretion, and that works in collateral with the other 2 pumps in steps 2 and 3 there. So these are the major biochemical findings you'd find in adrenal crisis. Just thinking about these functions, if you lack aldosterone, you will thus get hyponatremia, hyperkalemia, a raised urea because of decreased renal perfusion with low blood pressures, and a metabolic acidosis as a result. Also important to think about the functions of cortisol. Cortisol is a lipid-soluble hormone, effectively, and it crosses all membranes, and the receptors are actually intranuclear. So all cells have receptors for cortisol, and it effectively makes sure that there's enough ATP available for use as fuel. So it increases gluconeogenesis in the liver, it increases glycogenolysis in the liver and in the periphery, it increases lipolysis in the liver and in the periphery, and it decreases protein synthesis in the acute phase, which I thought was interesting. So talking about primary adrenal insufficiency, it's effectively when the word primary implying that the adrenal itself is at fault. Secondary and tertiary, thus meaning that secondary, the pituitary gland is at fault, and tertiary, that the hypothalamus is at fault. But in primary adrenal insufficiency, you can see that there's decreased cortical production for some reason, that the adrenal itself is damaged. And this causes decreased inhibition of the HPA axis, and thus increased production of CRH and ACTH. And that's the kind of uncontrolled negative feedback loop that happens. So what are some causes of adrenal insufficiency? Primary and secondary causes. The important things to know, this isn't even an extensive list. There's lots of stuff happening here, but can be autoimmune. So a primary autoimmune adrenal insufficiency that occurs in isolation is known as Addison's disease. But it can take place as part of a polyglandular syndrome. Infections in our context, TB is the big one that can cause this adrenal, effectively just necrosis of the adrenal glands. Bacterial sepsis, and the kind of famous name that everyone thinks about is Waterhouse-Friderichsen syndrome in the setting of meningococcal infection, that these patients with the onset of severe systemic sepsis and DIC get adrenal hemorrhage, thus damaging the adrenals and causing an acute adrenal crisis. Other infections can do it as well, though. So Haemophilus species, viral infections can do it. So HIV itself, HSV, CMV, adrenal hemorrhage can also occur in a few other contexts. So DIC in general, other coagulation disorders, warfarin toxicity, antiphospholipid syndrome in the kind of catastrophic setting. Infiltration over a longer period of time, rather not an acute thing. Drugs such as ketoconazole, and I think important for us in the ICU setting is etomidate and some antiepileptics. And then genetic causes, congenital adrenal hyperplasia and other X-linked nonsense. That's a bit too much. But the secondary and tertiary causes are also quite limited. So pituitary problems that cause a more acute thing is Sheehan syndrome, so acute blood loss or blood pressure drop in the process of labor and delivery, or similarly a pituitary apoplexy. So someone who's got a tumor and they kind of bleeds into that tumor can cause an acute thing in the context of someone who had an underlying chronic suppression of the axis. Surgery for these tumors, radiation for these tumors, and a rapidly aggressive craniopharyngioma. HIV can also do it at the pituitary level, and then in the hypothalamus, kind of anything intracranial can really cause these things, but strokes, head injuries, tumors, a whole lot of other stuff. In our setting and in the setting of the ICU, we just want to think about these as the major, really acute problems, something that can change acutely to cause an adrenal crisis, and those are the major ones. Understanding that anyone who has a chronic primary or secondary or tertiary adrenal insufficiency can thus also develop any of these problems and thus have an underlying baseline insufficiency that we would need to account for. So looking at features of chronic adrenal insufficiency so that we can understand these patients a bit better. Primary adrenal insufficiency can have all of the above. So fatigue, weight loss, GI symptoms, amenorrhea, myalgias, psychiatric stuff. It really is a broad spectrum. But those are all related to glucocorticoid effects. Only primary adrenal insufficiency, meaning that the adrenal gland itself is damaged, has problems with the mineralocorticoid effect as well. So those patients get postural hypotension, salt craving, and hyperpigmentation. They may also exhibit other autoimmune features like vitiligo. I thought it was just interesting to say how these patients get their hyperpigmentation is that in the stimulation under that negative feedback loop, the pituitary gland is thus stimulated to secrete ACTH. But ACTH is cleaved from a hormone called POMC, pro-opiomelanocortin, and the other half of that cleavage is MSH, melanocyte-stimulating hormone. So these patients get stimulated to get these dark patches in the skin, and actually once you treat these patients, that hyperpigmentation resolves in 3 to 4 days, which is quite interesting. So just to understand that when we look at the right, at the effect of aldosterone, at the effect of cortisol, how these things are accounted for in our patients. So really, adrenal insufficiency can present anywhere on the spectrum, from general fatigue and weakness, nausea and vomiting, abdominal pain, diarrhea, back pain, dizziness, hypotension. Sounds like anything you see in minors on any given day.
Back pain, exactly. You see that back pain.
But it can be also shock. So really just a very broad differential here, and we can see that as the classical lab and clinical findings suggesting adrenal crisis, dehydration, hypotension, or shock. And effectively, the text was all just any patient with an undifferentiated shock, you need to consider adrenal crisis as a cause. Nausea and vomiting with weight loss and anorexia, abdominal pain, including acute abdomen, unexplained hypoglycemias, unexplained fevers, hyponatremia, any electrolyte abnormalities, hyperpigmentation, and other autoimmune associations as well. So in the ICU, we need to think about our critically ill patient, and if we only consider the adrenal glands, what are the options really? So is the cause of this adrenal, yes or no? And if it is this an adrenal crisis, or I even spelled that wrong, a CIRCI, C-I-R-C-I, actually. And we'll go through each of those now. This is what I felt, even spelled it wrong. So investigation of a possible adrenal crisis. You got a patient who comes in with this undifferentiated shock picture. Maybe their chronic background history, according to the family, fits with our chronic adrenal patient picture. Or there's something that makes you concerned for another cause of an acute adrenal crisis. Bloods that are important to do is a VBG and a finger prick glucose, kind of in the very acute assessment of these patients. I mean, obviously we're going to approach with the ABCDE approach, but I think getting these glucose as quickly is important. And then a VBG will help us assess the glucose as well, but also the electrolytes and how severe this shock is. Formal bloods, a urea, a creatinine, and a free T4. Because these patients have problems with aldosterone, they do get effectively pre-renal because of the effects on the afferent arteriole in the kidney. So urea, creatinine are both important. And then very similarly to an adrenal crisis, you can see patients who present very similarly in patients who have a hypothyroid crisis as well. Serum cortisol level, in theory, should ideally be done before initiating therapy. But we very, very rarely think about this in our patients. We obviously often have other ideas about what the cause should be, and it's very rare that we're considering adrenal crisis as the primary cause of this patient's shock. As you see, even acute abdomen can be something that the patient experiences, and in which case this patient would probably end up in theatre before we, do other things. So just understand that ideally it should be done before initiating therapy, but we'll talk about it later. And then investigating other causes. So if you're worried about sepsis, appropriate cultures, including blood cultures, sputum cultures, urine, anything that you can identify as a possible source of sepsis. An ECG would be important. Imaging, including chest x-rays or abdominal ultrasounds. And then surgical investigation as well. A negative laparotomy might give us some idea of what's going on. And I think something that as physicians, we kind of want to include as part of our vital signs is a urinary dipsticks. It really just gives a lot of information about what's happening with these patients. And then I just brought back that biochemical findings little block there as well, so that this is what would lead you to suspect an acute adrenal crisis, having done these investigations. So the first option in the setting of ICU is, now this patient's been in ICU, you've done the initial management, the initial workup, and you're concerned about an adrenal problem. There is an entity that initially was labeled relative adrenal insufficiency, or RAI. This is like late 90s, early 2000s, when people started thinking about these patients that have what they term this relative adrenal insufficiency. And over the last 2 decades, a new term was coined in about 2018, CIRSE, or critical illness related corticosteroid insufficiency. And it's a bit of a complex, weird to understand topic, but I find it easier to define it by what it's not. So what it is not is an exacerbation of impaired function of the HPA axis that already existed before the current critical illness. For example, in patients with known Addison's disease, or patients that we often have in internal med on chronic steroid use, who now get a critical illness and their steroid requirements jump. That's not a CIRSE. Something else that's also not a CIRSE is the need for exogenous corticosteroid use in the setting of septic shock requiring inotropic support. So it's just important to understand that those things are not this entity that we're talking about. And a working definition of CIRSE could be that it is an acquired state of central adrenal insufficiency in prolonged critically ill patients. Now, we hardly ever have patients who stay in our ICU for several weeks. We got Stoop out now after 9 days or 10 days. You know, and that was the longest we've had in a while from internal med side. I don't know how long the surgical patient. Yeah, a while. But you know, several weeks is what, and they don't put in time on it in the studies, but they're saying that several weeks is probably the amount of time that is required for the set of inflammatory processes, drugs, other significant ligands in the inflammatory cascade, bile acids specifically have been identified, and then hypercortisolemia in general, just to suppress this axis, thus creating the concept of CIRSE, or the kind of milieu in which this thing is defined. So prolonged critical illness with hypercortisolemia and high circulating bile acids and other exogenous GR ligands with modifiable risk factors. In that setting of a prolonged critical illness, all of this might work together. And something that they've done so many studies looking at, should we measure ACTH to identify this? Should we measure random serum cortisol? Should we measure 8 AM cortisol? Should we do dexamethasone suppression testing in these patients? And effectively, in the critical illness setting, it could be anyway. You really never know what you're going to get, and as such, there's no clearly defined limits that would help you to make a biochemical diagnosis of this entity. But it's just something to understand that it may happen, and you would need to supplement exogenous glucocorticoids. And the way we really diagnose this is to try and see if the patient gets better. So that's just something to think about. In patients with known chronic adrenal insufficiency, you would need to then think about stress dosing of steroids for their critical illness period. So patients on chronic steroid replacement, you need to discuss with them and say, listen, if you do get ill, this is the plan. And if it's a mild illness, they can follow what they call the 3x3 rule. So to triple their usual dose of steroid for 3 days. So if you're trying to keep them kind of iatrogenically in line with their diurnal variation, you say that on 15 in the morning and 10 at night, you could make it 45 in the morning and 30 in the evening for 3 days.
But this is now for patients with chronic adrenal insufficiency, not patients taking cortisone for another.
No, this is for patient. No, but it's also for patients who are on chronic steroid replacement. Yeah, so because they would be on the chronic adrenal insufficiency patients are on steroids in any case.
Yeah.
So this is for rheumatoid arthritis patients or autoimmune hepatitis or whatever. So it's just to kind of tell them that your body will require more of this in the acute phase. I think we find it quite difficult to limit patients from doing this. They have a little sniffle and then suddenly it's on the steroids, and then they come in crushing weight. If they have a persistent illness, then they need to contact their physician. And if they are admitted, then they suggest giving hydrocortisone daily in divided doses. And then critical illness, labor and delivery are managed as per adrenal crisis management, which we'll get to. Surgery for you guys, these patients can be managed effectively as adrenal crisis patients, and then a rapid wean and taper to reinitiating their oral dosage on day 3 or 4 post-op, unless you're concerned about complications, and usually those are septic complications. For Muslim patients who are fasting, if they're on chronic steroids, you should ask them to change from whatever they're taking to prednisolone, just a little bit longer acting, 5 milligrams once daily, orally taken immediately before dawn, and that should get them through the period of time where they're not allowed to eat or drink their tablets. So that's just a consideration for these patients as well.
So you say for a surgical patient who's coming for another problem.
Yeah.
So you say you rapidly taper their normal oral dose, and then you IV hydrocortisone.
Yeah. So we'll get to the basically in adrenal insufficiency. They say that surgery, labor, delivery, and critical illness are approximately the same level of stress. And I'll get through what they say should be required for these patients now. But if they are on these things. So management of this acute adrenal crisis, obviously the patient's pre-op wouldn't be managed as in terms of their fluids, but the glucocorticoid therapy applies. So if you've got this patient as an acute adrenal crisis in EC or ICU, fluid resuscitation is important because of the effects on their renin-angiotensin-aldosterone system. They are often very dehydrated and hyponatremic. So thinking about your fluids, they do say 2 to 3 liters of isotonic crystalloid in the first 12 to 24 hours. But considering that these patients are hyponatremic, just think about which fluid is probably better. And also these patients are often, their glucose is also low. So a glucose-containing solution would probably be useful in the setting as well. But obviously you have to tailor this to each individual patient. And Ringer's lactate isn't that hypotonic. Just something to think about. The glucocorticoid therapy, hydrocortisone, is the suggested drug of choice for most patients. They say that if the patient is receiving more than 40 milligrams of hydrocort daily, it then in those doses has sufficient mineralocorticoid effect to cover the aldosterone side of things as well. So 100 milligrams IV stat and then 50 milligrams IV 6 hourly. Times 4 doses. So it effectively works out to 200 to 300 milligrams in the first 24 hours. And then weaning to 50 milligrams 12 hourly and then tapering over 1 to 3 days. Although there's no clear guidelines on how to taper these patients. And that's the point that you would then start the patient again on their oral, their pre-existing oral therapy. So it's important to note that you can add fludrocortisone. So 0.2 to 0.5 milligrams daily. The 0.2 is what's recommended on UpToDate. And that's for patients who are receiving dexamethasone or methylprednisolone for their other underlying conditions. Let's say we've got a patient who's got a primary pulmonary hemorrhage syndrome and they're being pulsed with methylpred, but you think they're having the acute adrenal crisis on the side. In order to cover for the mineralocorticoid requirements, fludrocortisone can be added. But usually this is occurring on consultation with endocrine specialists. Yeah, so the third topic around steroids in the ICU with this adrenal topic, and it's something that we decided that CIRSE was not, is the use of steroids in septic shock. And I've just kind of covered this very briefly. So there are trials that showed benefit and trials that showed no benefit. Some trials that showed benefit were a French trial and the approaches trial, and those showed some benefit in mortality. The 2002 study showed a 28-day mortality increase in 6% and decreased the duration of inotrophic support required by 17%. The 2018 study is the same regimen and the same group of people and the same hospitals. So that could be a little bit of a bias there just by the study, but it showed that it did decrease 90 and 180-day mortality. There was no increases in secondary infections observed, but it did show an average increase in the HCTs. Those are the two kind of usually highlighted studies that showed benefit to mortality. Important to note there that also those the two studies that included fludrocortisone in their regimen, whereas the studies on the right-hand side that only used hydrocortisone showed no benefit to mortality. And then a meta-analysis that was done of all of these studies included both the no benefit and the benefit, showed, and a few others that aren't included on this slide, showed that there was minimal significant benefit to mortality over any time period, but it does significantly decrease the duration of vasopressors required in the ICU setting, and thus the length of ICU stay, which is kind of a secondary outcome. So, management of these patients, steroids in septic shock, again, 200 to 300 milligrams of hydrocortisone daily in 4 divided doses, so 50 to 75 milligrams 6 hourly. Fludrocortisone only in selected cases, patients with known congenital adrenal hyperplasia, those sort of things. Not 57, sorry, 5 to 7 days duration of therapy, and there's no clear evidence guiding the taper period. Some experts discontinue immediately, some taper over 5 days. So it really is kind of up to you and how you think your patient is doing. But understanding that this isn't to do with the reason we're giving steroids for these patients is not because of the effect on the adrenal glands, but because of a direct pharmacological effect of the corticosteroid causing peripheral vasoconstriction and helping with effectively keeping the blood pressures up and thus decreasing the requirements of for vasopressor support. So those are the major topics. I think in ICU, it's just important to understand that these patients, we don't think about adrenal crisis often, and it may be a cause. There's no clear clinical or biochemical means of making this diagnosis, with the exception of perhaps doing a random serum cortisol. And if it's less than 500, then boom, you know, then it's too low. But if it's more than 500, that doesn't rule out an adrenal crisis either. So you have to kind of assess your patient and see how things go. Thinking about the concept of the CIRSE, it's really in patients with prolonged ICU admissions where the adrenal glands, inflammatory cascade setting, the down regulation of the binding hormones, so the sex hormone and the corticosteroid binding hormones, or binding proteins rather, in the blood, that down regulation causes initially an increase in the circulating free cortisol level, the active component of cortisol that's measured. But as then the inflammatory process goes, there's no more binding proteins to circulate these things. So it's initially a compensatory mechanism that then later on in the process works against itself. So just something to understand. And then the use of steroids in septic shock is not to do with the adrenal crisis that we think it may have caused, but because of its own indication as a separate entity. So that's the topic in a nutshell. There's the studies that I looked at and the up-to-date articles as well.